Good evening, everyone, and welcome to the Living with HIV and Type 2 Diabetes webinar. I'm Destiny, the media strategist for Seeds of Healing. Seeds of Healing is an HIV awareness and advocacy organization whose mission is to deconstruct myths that perpetuate HIV stigma. Our work seeks to eliminate disparities for Black women. This webinar is being recorded and will be shared on our SOH Time platform and posted to our YouTube channel. So if you do not wish to be recorded, you may excuse yourself, but the panelists will only be on video today. Attendees are able to drop questions in the chat box and they will be shared at the end of the webinar. So please feel free to ask any questions or write comments in the chat box throughout the entire program. Today's webinar is a SOH Time event, and SOH Time is a virtual platform for Black women living positively. Here is a short video to tell you a little bit more.
Hey ladies, welcome to SOH Time. My name is Benita Spradley, one of the moderators and content contributors here, and we're excited to have you aboard.
Hello, Queens, and welcome to SOH Time. I'm Tamisha Isaac, also one of your moderators and content contributors. I'm honored to have you join us.
SOH Time is a platform for Black women to connect across the U.S. to provide tools for self-care and encourage consistent adherence.
SOH Time is a platform for us, created by us, to collaborate and center issues that affects Black women, the struggle causes by a diagnosis or chronic illness.
We have groups with specific topics to cater to the mission of SOH Time, but uplift, empower, and strengthen you as we power through on this journey.
Surrounding yourself with women that look like you in a safe space where you are free to be yourself while learning from each other and sharing resources that can enhance your way of life on the course of this journey.
We are here for each one of you. We welcome you, and we look forward to networking, supporting one another, and learning new things as we come together on this SOH Time website.
Welcome.
Thank you. So a quick introduction to our speakers today. We have Dr. John Melo, who attended medical school at LUCOM. He's a first-year family medicine resident because the specialty provides full scope training, which will allow him to work with a broad range of patient populations throughout his career. Long term, he hopes to work with underserved populations and teach residents and medical students. We have Dr. Carol Zeltzer from Arizona. After undergrad, she started her career in children's behavioral health, working with a variety of children from disadvantaged backgrounds, including the foster care system. Dr. Zeltzer initially went into medicine interested in pediatrics, but quickly realized that her passion was full spectrum women and children's health. She's excited to be in Wilmington practicing family medicine as a first-year resident. We have Dr. Austin Sherman, who studied medicine from St. George's University in Granada and Chicago, where he worked with underserved communities. Dr. Sherman was drawn to family medicine during med school and now serves as a family medicine resident at Hanover Regional Medical Center. And finally, we have our very own SOH Time moderator, Tamisha Isaac, who is an openly positive HIV activist of global empowerment movement. She encourages others to not allow a diagnosis of HIV to deter them from living out their dreams while bringing awareness and HIV education to communities worldwide. Without further ado, I will turn it over to the residents.
So thank you for that wonderful introduction. Just to kind of go over again, I'm Dr. Sherman, I'm Dr. Melo.
And I'm Dr. Zeltzer.
We're so honored to be here with you guys to kind of help give some information about diabetes. We just want to thank Seeds of Healing first and foremost for giving us the platform to be able to get this information out. I know this was mentioned before, but if there are any questions, please feel free to drop them in the chat box as we go along. We'll try to explain the PowerPoint as we go through it. And then also, if you want to have an open discussion at the end, we are open to any of those questions that you may have. And then without further ado, I'll go ahead and try and share my screen. I know sometimes this can be a little interesting. All right, can everyone see that? Awesome, so we'll go ahead and get into it. And this is just a quick disclosure. We basically have nothing to disclose, nothing financial. We are residents with New Hanover Regional Medical Center in conjunction with Coastal Family and Novant Health. However, this PowerPoint is in no way meant to be for use for any type of monetary gain. It's only solely for educational purposes and to have open discussion. And then just kind of going in, so what we really aim to do during this webinar is kind of explain the basics of what diabetes is. There's two different forms. We'll get into that, discuss why diabetes is important, why should we look out for it, and why we should be looking out for it, not even in ourselves, but in people that we live with or might know. Some of the long-term complications that it might have and how it actually pertains to the community itself. We'll look at the different risk factors for diabetes, and then also some of the management options that diabetes has, and then some of the side effects and how it might interact with other disease processes such as HIV. And then, like I said before, we will have open discussion at the end or time for any questions near the end. Please feel free to drop your questions in the chat box as well. Alrighty. So just getting into it, just a brief introduction. Diabetes, as I'm sure most of you know, or many of you know, it's a disease that is prevalent in the United States. It's a very old disease with history dating back to as far as about 500 years. And interestingly enough, we'll give you some percentages, but it actually disproportionately affects minority populations in the United States. We can kind of go into why that might be later on. Like I mentioned before, there is two different types of diabetes. You do have type 1 and type 2. Trying not to get too much into it. Type 1 is kind of what people are born with more so. You kind of develop that at an early age. The pancreas is one of the organs in the body that helps control the sugar in the body. And that organ doesn't work functionally to help control that sugar. While type 2 diabetes is kind of the more prevalent kind, probably more so familiar in the community. That's kind of the one that when your body kind of builds resistance to the amount of sugar in your body, that you kind of can develop later in life. Can also happen when you're younger in your teenage years as well, but typically a little bit later in life than type 1 diabetes. And then this is a good graph. This is something that we pulled actually directly from the CDC, I believe. It kind of goes over what we test for as physicians, what we're looking for. I know this can kind of be a lot sometimes, so I'll try to break it down as best I can. There's 3 tests that we typically run when we look at diabetes, one being an A1C, the other being glucose tolerance testing, and then your fasting blood sugars. As you can see at the top, those are all diabetic ranges. I know the A1C can be a little arbitrary, but that's something that you might be familiar with talking with some of your physicians, or if you have a diagnosis of diabetes or know someone in your family or friend or what have you that might have diabetes, you might hear them say the number A1C. Essentially, what we're looking at is a number that's above 6.5. Once we start getting above that 6.5 range, we really have to start talking about different management options and kind of things that we're looking for to help combat diabetes and the complications that we'll get into a little bit later on. The other 2 tests look at the amount of sugar in the body at a current time. Glucose tolerance test being if you were to eat something, we'll see how much your blood sugar rises after you eat or eat that certain object. And then a fasting blood sugar being if you slept for 8 hours, what would your blood sugar be? So those are just some numbers to look out for and what we look out for. These are all blood tests, just so you know. So those are kind of the standards that we look at in terms of diagnosis.
Now we're going to kind of get into epidemiology and kind of our word for describing how prevalent is this in the community. Unfortunately, diabetes, it affects 425 million people worldwide. And it is more type 2 diabetes. So among adults in the US, 7% have this diagnosis, and that's 23.1 million. And of that, 95% of those are actually type 2 diabetes. So people are more likely to have type 2 diabetes. If you know somebody, it probably is type 2. because that's something that you can acquire later on in life. And as Dr. Sherman mentioned, it does disproportionately affect minority populations. So starting with non-Hispanic white Americans at 7.4%, and then all the way to the non-Hispanic Black Americans at 12.7%. So we can see that it really is increasing, and it is a big problem among these minority populations. And that's why we're so concerned about it and wanting to target it early on. And then specifically in the population of patients with HIV and diabetes, people with HIV are more likely to have type 2 diabetes than people without HIV. And one study showed that the numbers looked at, it was about 4 times more common in people with HIV than the general population. We think that exposure to some of the older ART agents, antiretroviral therapy agents, were associated with this insulin resistance, and that causing the increased incidence of diabetes. But that is sort of still a work in progress of trying to figure out what the actual cause is. Some of the clinical factors, some of the clinical risk factors for diabetes, because, you know, as we're kind of going through this, we want to think about what is our risk. And you can kind of ask yourself which category you fall into. So as we're going through this, just try to think about your own personal experience and your own health history. So for family history, if you have any first-degree relative that has diabetes, you have a 2 to 3-fold increase in the risk of developing it yourself. And if you have both a mom and a dad that have diabetes, your risk is 5 to 6 times increased than the general population. Ethnicity, we already touched on. If you're in any of those minority populations, unfortunately, you are at higher risk. Also, your risk increases just as you get older. Older people are more likely to build up insulin resistance over the years. If you have gestational diabetes, any of our pregnant women population might be very familiar with this because you probably had a glucose tolerance test in pregnancy. And that's where we're screening for gestational diabetes and trying to see if you are in this at-risk population. And if, unfortunately, if you end up having gestational diabetes, it can end with just your pregnancy, but it puts you at a higher risk of developing diabetes later on in life. Another risk factor is polycystic ovarian syndrome. Obesity, just in general, being at a higher body mass can increase your risk, as well as high blood pressure, and then abnormal cholesterol and triglyceride levels. So if you have high fat in your blood, that's going to be one of the risk factors that we look at as well. There are also some lifestyle risk factors. So before I kind of go into this, I just want everybody to take a moment and think about kind of your own personal habits. How much do you exercise on a daily basis? What kind of exercise do you do? Are you a smoker? How long did you smoke if you quit? And then the last one is kind of interesting, but sleep duration. How are you sleeping at night? How long are you sleeping? What is that sleep quality like? Because all of those can affect your risk factors. And these are all things that we can, we can control. So some of the things we've talked about before are, just kind of the cards you've been dealt with. But these are things that we can actually pinpoint and take control of ourselves. So for exercise, if you have a sedentary lifestyle, basically that lifestyle is promoting the weight gain, and the weight gain is increasing the risk of diabetes. So that's how that progression works. And I thought this was interesting. Of those, prolonged television watching is consistently associated with the development of obesity and diabetes. So I know all of us are guilty of binge watching. We all watch our shows.
Yep.
But this is an area where we can try to, build in some fun little ways to get going and just keep up a little bit more active lifestyle. And Dr. Melo is actually going to get into that later, so I won't step too much on that. But I just want us to think about that aspect of it. Smoking, if you're a current smoker, you have an increased risk of developing type 2 diabetes. So this is a great time to think about quitting and to think about the long-term health effects, not just of cancer and lung cancer, the things we commonly think about, but of diabetes. And then sleep duration. If you have shorter durations of sleep, that's significantly associated with an increased risk of type 2 diabetes. So you can say, doctor's orders are that I have to sleep. And you now have an excuse to take a nap.
Can I tell that to my
You can-
6-month-old?
Yes, tell it to all your kids too. Say, I need my sleep so I don't get diabetes and get sick.
I think that's a question.
Yeah, let's go with the who also keeps bringing down.
Netflix is a problem as well.
Yes,
Yes,
yes.
we agree.
I blame Netflix. What was that top one?
I think it was just an introduction.
Okay. So signs and symptoms of type 2 diabetes. So interestingly, on diagnosis, many patients are totally asymptomatic. So the reason I want to tell you that is that a lot of us could be walking around and have diabetes and not even know it. So these are some things I'm going to talk about, some classic symptoms of, yes, we see this in people with diabetes, but what I want you to remember is that not everybody's going to have these symptoms, and you could be walking around with none of these symptoms and still have diabetes diagnosed on the blood test that your doctor would do. So increased thirst, frequent urination, if you find yourself peeing a lot, drinking a whole lot more than normal, having extreme hunger, unexplained weight loss, fatigue, irritability, blurred vision, if you have slow healing sores, frequent infections, those can all be things to look out for. But more importantly, I want you to remember you could be totally asymptomatic and have diabetes. And then Dr. Melo will touch more on what you need to do in that scenario and what to talk to your physician about. So the reason that we really truly wanted to do this talk was honestly for this slide, because what are the long-term consequences of diabetes? Diabetes is one of those things, everybody knows somebody with diabetes. We've all heard about it. We don't want to get it, but why do we not want to get it? What does it really do to us other than make our sugar high?
Yeah.
So these are the things, the complications that can happen once you get diabetes. We're going to go through these a little bit. So cardiovascular disease. Once you have cardiovascular disease, that means that you have plaques or fat lining the inside of your blood vessels, making it really hard for that blood to pump through. Once you do that, you've caused yourself to have high blood pressure. And if we get into that scenario, then your body is having to work really, really hard to pump the blood through your body, through your heart. That's what we call the cardiovascular disease part. And that puts you at a greater risk and that is one of the long-term complications of having diabetes. So is there anything more you wanted to add to that?
Just, obviously these are great. And obviously these are some of the main causes, but there are others. But I think you're doing a great job kind of explaining what we're looking out for.
One of the other things is nerve damage or neuropathy. Neuropathy is the fancy word that you may hear your physician use at some point. But if anybody has a friend or a relative who's lost toes or feet or legs to diabetes, this is what happens. Your body just cannot get the blood supply to the nerves that are in your lower extremities. And once you lose that, you can no longer have blood flow and supply to those nerves. And that is when we start having to amputate things. So that's definitely something we want to avoid. Nephropathy or kidney damage is where the really high blood sugar goes and essentially damages your kidneys. And now your kidneys can't function to excrete the urine in the way that you normally would. And that can give you chronic kidney disease. Another common thing is retinopathy or eye damage. So similar to neuropathy, if you can't get blood flow to the vessels that go to your eyes, then your eyes can't see anymore. And that's what we call retinopathy. Foot damage, we kind of already talked about. Skin conditions. Another really interesting one is depression. Having diabetes can be very stressful. And people who have very far advanced type 2 diabetes, they're having to have all these medications. It really affects your overall quality of life, especially the longer you have it. And we see in those patients, they're at a much higher risk of having depression and having to deal with all the anxiety and emotions and sort of problems that come with having a long-term illness. Specifically, the relationship between HIV and diabetes, the relationship between HIV and diabetes is really interesting. So we have our ART medication, So high blood sugar, the way that it kind of breaks down, high blood sugar is a side effect of some of the ART treatment for HIV. So people who are taking some of these medications may be at a greater risk because they then have higher blood sugar, and then they can also have diabetes. The newer HIV medicines don't seem to come with the same risk, but you may have been on some of this ART medication in the past, and we'll go over specific ones in just a little bit. And then some ART is used to treat HIV may cause people to gain weight. And kind of like we mentioned before, it's the weight gain that causes the increase in risk for diabetes. And then the people who are HIV are already at higher risk of having diabetes, so they've kind of had a double whammy, if you will. Many people with HIV also have hepatitis C infection, and hepatitis C has been linked to diabetes. There's a lot of co-infections with hepatitis C, Hep B, and HIV. So that's something that we see a lot, and you want to maybe be aware that they also need to think about having diabetes at that point. And then interestingly, people who have HIV, the body is just more inflamed. There's more inflammation in your body because the virus itself is still there and there's still replication. And so if it's not at a controlled level, that just can cause inflammation in your body, and the inflammation puts at an increased risk for diabetes. So the next is ART therapy and diabetes. So this slide looks very wordy, and I don't want you to get overwhelmed and too bogged down. But the reason that we left it in is because I want the names of the medicines to be in there. Number one, so that you can look and see if it's a drug that you've ever taken, if it's a drug that your doctor ever says, hey, maybe you should go on this. Now you have a little bit more information. So protease inhibitors like indinavir and lopinavir, those have been shown to cause insulin resistance and high blood sugar. They're generally not used today, but something you may have taken in the past. Several studies have noted an association between a long-term exposure to older NRTs, nucleotide reverse transcriptase inhibitors. So I don't know how to say this. Zidovudine, stavudine, didanosine. Those have a propensity of causing greater insulin resistance and thus the diabetes risk. And then some of the newer treatments, the integrase inhibitors, dolutegravir, bictegravir, raltegravir, and elvitegravir. Those are a mouthful. They've been associated with weight gain. And then, as we already talked about, the weight gain causing the diabetes, causing the risk factors. So those are the medications specifically that if your doctor brings up, that you maybe want to talk about and say, you know, I have a family history of diabetes, and I maybe have a sedentary lifestyle. Maybe adding this specific medication wouldn't be a great fit for my life. Maybe try a different one. So that's why I wanted to leave those ones in.
So now we're going to transition a little bit to talk more about kind of lifestyle adjustments, which Dr. Zeltzer's already touched on a little bit, as well as briefly talk about some management options, but not go too much in depth with that. I do like this picture on the slide. I think it does a really good job of kind of hitting kind of hitting on all the topics that we'll go through kind of systematically. And this acronym is good. So the T standing for taking your medications is prescribed, which we'll talk about. The R for reaching and maintaining a healthy weight, which is super important, not just for diabetes, but for a lot of chronic diseases and for your health overall. A, to add more physical activity to our daily routine, which I think as we've discussed before, we probably all spend a little bit too much time on the couch watching Netflix or Hulu, and could definitely be a little bit more active. Although I think Dr. Sherman has us all beat in that regard. Spends a lot more time in the gym than most of us. C for control your ABCs. So again, your A1C, your blood pressure and your cholesterol levels. And then K for kicking the smoking habit, which Dr. Zeltzer also discussed a little bit. So in terms of healthy body weight, I don't know, this slide may be a little bit difficult to see, but a healthy BMI, so body mass index, is less than 25. And just kind of for understanding, a BMI is calculated using both your weight and your height. When you go for an appointment with every provider, generally they'll take your weight at most visits, and they'll have asked you about your height previously or ask it then. Sometimes they'll measure it, and then we use that simple calculation to get your BMI. Again, healthy BMI is considered less than 25. And generally speaking, this is achieved through eating healthy foods and exercise, being more active. A healthy initial weight loss, when we look at counseling patients on trying to progress towards getting a healthy body weight, is to think about losing about 7% of your body weight. And a good goal, if you want to break that down into pounds, is to think about losing like 1 to 2 pounds per week. And kind of other information that I looked up when trying to look at that kind of 7% of losing that body weight initially, is to think about 5 to 10% of your total body weight. And if you do that, you can actually decrease your risk factors associated with chronic diseases. So not just diabetes, but hypertension, or high cholesterol, heart disease, liver disease, blood pressure, other things. So again, not just important for diabetes, it's important for being healthy overall, and for helping both manage and prevent a lot of the chronic diseases that we're all prone to developing. In terms of options for food or dieting, you always want to think through balanced meals, and we'll talk through some kind of different potential diet plans, and don't really want to focus specifically on those necessarily, but more so on kind of the types of foods that we should be eating. When you think about balanced meals, you want to consider eating less than 25% of our calories from fat. I know that one of the fad diets now is keto, which is very high in fats, and there's some controversy over that. Some people in the medical field are very much in favor of it. Some are not. So if you decide to go that route, that would be definitely something to discuss with your provider. But in terms of calorie intake from fat overall, definitely want to consider most diets being less than 25%. We did have a question concerning about intermittent fasting. So there have been quite a few studies now about intermittent fasting that have actually shown quite a bit of benefit, not just for chronic diseases and health, this kind of portion of health, but they're also actually looking at it in terms of mental health, in terms of dementia and Alzheimer's, and the benefits that it has in those settings. It's in a sense fairly new in terms of kind of their research market and what they're looking at. But again, from the few studies that I've seen in the past few years, it seems like there is quite a bit of benefit from that. When you talk about intermittent fasting, you have to define what you mean in terms of intervals, because some studies, when you look at them, say that's more of like an 8 to 10 hour period. Some of it looks at fasting for 7 or less. Some of it look at just eating 1 meal or 2 meals a day and then skipping others in between, or combining those two and then not eating basically through the evening and through the night, and then up until like the next morning at 10. Some say only eating between the hours of like 10 and 3 or 4 and then skipping the rest. So again, I think there are definitely good benefits to intermittent fasting, depending on what study you're looking at, but it can be different depending on what you define as intermittent, and what the hours look like for that. We also had a question about just balanced meals and what that looks like. And so on our next few slides, we'll kind of walk through a couple different diets that really talk about, and I think do a good job at showing what balanced meals look like. So we'll hold off on that until we get to those. Yeah.
So just to add quickly onto intermittent fasting, I think Dr. Melo did a great job explaining kind of what it is and kind of providing, the health benefits. And I do agree with him in terms of there are health benefits that can be, retained from intermittent fasting. But I think just kind of also trying to stress the fact that if you do it correctly, that is kind of where the health benefits are. I've definitely had patients in the past that have tried intermittent fasting and have not done it properly. And if not done properly, it can be, somewhat dangerous. You could get that starving or starvation type, eating habits. And that's never something that is that we recommend to any of our patients. If there are further questions about intermittent fasting and kind of how to do it, we can maybe talk about that at the end. Or it's a great question to ask some of your physicians as well, and just kind of, see if that's something that they think is, good for an individualized person, because it, although there are some studies that say that it's, great, and I do agree with that, but it might not be for everybody. Just to throw that in there.
Can I add my 2 cents in on that? too?
Sure.
Just if you're anything like me and you go for a long period of time without eating, like as soon as I'm done with that, like the first thing I want are like donuts and cheesecake. So I can maybe intermittent fast, but then what I'm going to eat on the other end of that is probably not going to be like carrots and celery. You may have a lot more dedication than me, but I don't know. I find it really hard to fast and then make healthy food choices in like my starvation brain. So but the research is legitimate. So.
And again, it's very much ongoing. It's a newer topic that's really being studied currently to kind of show benefits. So definitely a work in progress in terms of our understanding of how it works and what benefits it has. In terms of number of calories, so you definitely, it varies depending on your current body weight if you want to look at maintaining your current body weight. So for someone who's about the 170 pound mark, if you're just looking at maintaining body weight, you think about 1,500 calories a day. And then going up from there, it kind of moves up depending on your body weight, current body weight, to 2,000-ish to 2,500 calories a day. That being said, when we're thinking through that, that's not to say that you want to continue eating that amount of calories if you plan on losing weight. So again, if, for example, you're at 175 pounds, as an example, 1,500 calories a day would get you to about maintain that weight where you're currently at, which for some people is good, depending on, again, on their height, their overall body mass, muscle mass, everything else. Like 175 pounds may be great, and you just want to maintain that. For people, again, another example would be around 250 pounds, then your daily max would be around 2,000 calories that you have to consume in order to maintain that body weight. And so if you want to lose, then you have to think through, well, what do I need to cut out or cut back on to maybe consume a little bit less calories to help me lose weight so that my body starts burning kind of stored calories that I have. And so that's just kind of a good way to think about what I need to do to maintain if I'm at a healthy body weight versus if I need to lose, what I kind of need to cut back on in terms of calories to help me with that process. Question, and I think this is very important in terms of thinking through healthy food options before we kind of go into a few diets and looking at balanced meals. Where do you spend most of your time in the grocery store? And so we ask that question because something to look out for when you actually go to the grocery store next time. But most of the healthy foods are actually in the perimeter of the grocery store, meaning if you came in through the front by where all the fresh fruits and vegetables are, and you walked without going into any of the middle aisles, basically if you walked around the outside, you would find that most of the healthy foods in the grocery store are all on the outside, basically wall, as you walk throughout the grocery store. And so I know for myself, there's a lot of times where I spend a lot more time in the aisles.
They don't keep my cookies on the
Picking
outside.
out a lot of processed things. Yeah, for sure. Cookies, like you're not gonna find the Oreos next to the
milk.
apples or the milk, or the milk,
Which
but
you
you need
would
the milk
think
to dunk
would
it,
make perfect sense.
Yeah, but again, definitely more healthy on the outside. And so it's definitely something to think about every time you go to the grocery store. Where am I spending most of my time?
You and I both, we both spend the most time in the snack aisle, unfortunately. Moving on.
Yeah. All right, so we have a few diets here. The DASH diet is one that has been heavily researched actually for blood pressure. But they have had some cross-coverage research when it looks at preventing heart disease and stroke and diabetes, as well as some cancer amongst patients when they were looking at their studies with blood pressure. And so I think this graph does a really good job at looking through kind of a balanced meal. And it talks about different servings. And this is something that you can look up online, not just for this diet, but for any diet when you're looking at different types of diets, to figure out how much of each thing should I be eating. So for example, if we look at the DASH diet, which again has been very well studied and is a good healthy diet overall, if we look at kind of the top of the circle, it says 6 to 8 servings per day for whole grains. And by whole grains, that they're generally not meaning like processed foods, processed carbs, processed like white bread, for example, versus eating a whole grain meal with rice, for example, whether it be brown rice, eating whole grain breads. If you look and kind of come across where a lot of us want to spend more time to the lower kind of right side of it, it says less than 5 servings per week of sweets. So I know for myself, it becomes very easy when I want ice cream to go grab ice cream out of the freezer, and I probably eat 3 servings in a bowl when I eat it at one time, versus 1 scoop eating a lot more than that at one time. So just things to kind of be mindful of, and you kind of go around and figure out each servings, and you'll notice that the servings per day are highest for things like your whole grains, your vegetables, your fruits, your leaner meats, and then it kind of spaces out to higher servings, but per week. So things like nuts, seeds, some of your beans, and then again, much less frequent per week for things like sweets that are very high calorie, but not nutritious for us.
Can I just, there was a question in there, it was jokingly about, I think, can I get this DASH slide for my fridge? And I just want to say, what is it?
Most indigenous
Okay,
people
yeah.
are diabetic. Yeah, that was actually one of our, I don't think you were
Yes.
here, but one of our first slides
Yeah.
was Native Americans have the highest
Have the
percentage.
highest percentage of diabetes. I was just gonna say, this is pretty much, I don't have the DASH diet on our refrigerator, but I do have the My Plate, which is like another version of how to split up your servings of dairy, meats, vegetables. And I put that up on the fridge, and I have my kids look at it, and they say, oh, I want blah, blah, blah. I'm like, well, how many servings of grains have you had today? And we'll look at this little circle, and I'll be like, have you had any of this color blue? Have you had any vegetables? Have you had any dairy? And I make them go around the circle all the way before they get to go back to their carbs. My kids always want carbs. And so I'm like, no, you gotta have a vegetable, you gotta have a fruit, you gotta have a dairy, you gotta have a protein before you get back to your carbs. And so we talked about going around the circle a lot. So I think it's a great thing to put up on your fridge and just have a visual reminder of, keep in mind what serving size look like. Yeah, My Plate, yeah.
Another other diet that has been very well studied and is very helpful for a lot of chronic diseases in both prevention and helping to treat, is a Mediterranean diet. And I like this one in terms of the style, because I think with the pyramid, again, it shows us very about there. And again, the sweets, so a lot less of those per day and per week. And as we move down, we're looking at leaner meats, so chicken, eggs, cheese, and yogurt. And then looking at fish and seafood. And finally, the biggest kind of base for this in terms of foods is our vegetables, our fruits, our whole grains, beans, nuts, seeds, those kinds of things. And so that's really what we should be, much less of the things that are towards the top, and eating a lot more of the fresh things.
Great, yeah.
And then there's a few more things to this that I actually really like, is that they included within the Mediterranean diet, they actually incorporate the idea of physical activity and enjoying meals together, which I know has been very difficult amidst COVID, especially if you're trying to get together with extended family, with friends to enjoy meals. But I think it's very important to both, again, be active while doing these things, but also to engage with your community and those people around you to do the same. I think we'll have a lot better success when we do things together than try to do them alone. And so I think that's a major point to this, that if we can learn to sit down, put our phones, turn off the TV, and enjoy, and we have just a healthier balance for life overall. It's very important. The only other two things that I want to point out on this slide, one is definitely want to drink a ton of water every day. 8 kind of glasses is the recommendation, but I think as much as you can get in and more is probably better, and cutting out things like juice, sodas, those kinds of things. Sweet tea, we are in the South.
Yeah.
And then the other thing that this slide points out is wine in moderation. And so I want to go ahead and define moderation. So this is not an endorsement on our part to say you should definitely drink wine by any extent. These graphs often pulls in because it's a cultural aspect. Is that the wine is lined up with the fish and seafood, which it says twice.
At least twice.
But that being said, I would than twice a week. So I don't want us to get confused in the silo, and so we can definitely add in, some red wine whenever we want. That becomes unhealthy, and so this is not my endorsement to say go out and drink some wine with your Mediterranean diet. If you do, definitely in moderation, and we definitely say maybe twice a week or less.
And there was a comment about smoothies, which smoothies can be good in terms of what you put in, but sometimes if you put a lot of sweets or juices that John was talking about, they can actually be kind of that secret quote unquote unhealthy food that looks healthy, and it's maybe it's green and full of other vegetables and vitamins, the other stuff. It's got to be a little careful sometimes with the smoothies. I love smoothies myself as well, but those have actually been known to spike your blood sugar sometimes. Especially in terms of talking about diabetes and going forward with that.
You have to be very careful drinking your calories.
Yes.
Because ultimately, the more that you drink calories, i.e. smoothies, things that are pureed, that kind of thing, it may get you the nutrition that you need, but oftentimes you end up shortly after. And so, end up eating regardless. And so drinking your calories oftentimes does not help you really eat a balanced diet or lose weight for that matter.
And Jeffrey, your question was about the sweet tea. I'm sorry. I think our point was we want to decrease the amount of sugars, the amount of juices, the amount of sweet tea that we're drinking, because those are the things that Dr. Melo is saying. So that's kind of drinking our calories.
Yes. So I think your safest friend is always to drink water, and to really cut out a lot of, again, the juices, the sweet teas, sodas, that kind of thing. Even if there's no sugar added or they are diet, they've actually been shown, this is kind of a side point, but there have been studies that have been done about the artificial sweeteners that we put in things actually stimulate the same process to increase our blood sugar that other sugars do to a certain extent. And so a lot of our diet drinks have those things in them, and they play the same role that drinking sugar does. So you have to be really careful with that. All righty, so moving on to exercise. So this is a recommendation that we give every patient in general, regardless of having diabetes or not. But the general recommendation for all of us is at least 150 minutes a week of moderate intensity exercise. And I want to go ahead and define moderate intensity exercise. So basically, if you are walking beside someone and you can carry on a full conversation without missing a beat, I would not define that as moderate intensity exercise. If you are walking fast enough, or jogging, or running on a treadmill, biking, whatever it be, and you are struggling to talk to the person next to you without having to stop and catch your breath, that would be considered more moderate intensity exercise. Okay, so it's getting your heart rate up enough, you're moving enough to where you're able to focus on what you're doing, and I can't carry on a full conversation with Dr. Sherman while we're running on the treadmill together. You break that down, that 150 minutes, usually 30 minutes a day, 5 days a week. And so you get a couple of rest days in there. You definitely want to, as much as you can, split up your rest days, because it's recommended that you don't go any more than 2 days per week resting before doing another exercise activity for, again, at least 30 minutes. And then as you progress in exercise, you definitely want to consider adding in some resistance or strength training. With that, it definitely helps build muscle, which will help you burn more fat, and help build up your endurance for exercise. It also helps in terms of the as we age and building up, again, more muscle and stability, so that we have less frequent things like falls, injuries, that kind of thing. Some great examples, again, are walking, although depending on your pace of walking and who you're with, you may have to pick up the pace a little bit if you want to hit that moderate intensity exercise. Running is a great option. Biking, whether that be at home or hit the road or a trail. Exercise classes, there's a ton of virtual options, especially since COVID hit. That's become very abundant, and a lot of them are free. You can YouTube a lot of exercise videos and do them from home, so you never have to leave. So maybe in the midst of binge watching our show from Netflix, we switch to a 30-minute YouTube video of exercise, get up off the couch, and then after that we can, close out the night with another Netflix episode. YMCA or a gym, joining that, and again, even for affordability, there's a lot of fee assistance programs for some gyms and for the YMCA, so it can be definitely attainable. And then, like I said, home exercise equipment, which I think that market has boomed during the COVID pandemic because we were all stuck at home to a certain extent. So those are all definitely examples that you could do. There's also things like races in the community, sporting events. I know Dr. Sherman joined like volleyball league. And
Two-time champ.
There you go. We've got a champion over here next to us, gold medalist. And so those are definitely fun ways to find exercise and do that together with other people. Again, adding in that community and relational aspect.
Can I put in my 2 cents on it? Right? So I have a phrase that I want to use here that was spoken to me by a surgeon that I now just have to use all the time, and it's don't let perfect be the enemy of good. So this is the recommendation. This is ideal, and this is best case scenario, and this is where we want everybody to be, including ourselves. Now, I full disclosure, I am nowhere near this. I'm in residency. I have 3 kids. I have a baby. I am not doing this at all. So I can't let perfect be the enemy of good. What I try to do is, while I'm watching TV shows, get up during commercials. Just walk around my house. Just get in a little bit more steps. Try to do a little bit more walking in your day, taking the stairs instead of the elevator. Trying to make these smaller, simple changes, because right now the idea of going to a gym for me is very overwhelming with my life. And it just may not be attainable for all of us. So for sure, this is the recommendation. We would love for you to get 30 minutes a day, 5 days a week. But anything is better than nothing. And any physical movement you can add into your day, moving your legs up and down while you're sitting in your desk, standing up and walking instead of sitting down for a period of time. Literally anything is better than nothing. So I don't want you guys to get too caught up in these numbers and feeling like it's unattainable, so why bother trying? Keep up the great work. Try to get there, but it's okay if you can't. And just work up to it slowly.
All right. So in terms of other kind of components that may add to weight loss, and we won't go into this too extensively, but there are some medications that may help with weight loss, some of which are actually used to treat diabetes. So they have both functions. Some of them were approved initially to treat diabetes, and then have now been shown to help with weight loss. And so they're marketed for both. And in discussing this, and I've seen this with patients sometimes, that we want the medication, but we find it hard to do the healthy diet exercise, which is true of all of us, right? It sometimes becomes much easier to take a pill or a shot than to work in day out, to post something on the fridge and force myself and my children to go around the wheel, right? And make healthy choices, to get up and move around between a show, to take the stairs when it becomes much more convenient to take the elevator so I can look at my phone while I'm doing that, those kinds of things. So it's kind of small baby steps, but knowing there are some weight loss medications. That being said, they're not a replacement for healthy diet and exercise. And that being said, we won't go too much further into those because there are multiple medications, but definitely discuss those options with your healthcare provider if it's something you're interested in. In terms of controlling the ABC, so again, going back to that track chart that we were looking at, this is our C, and so you want to work with your healthcare provider to gain better control of these few things. So one is your A1C. Again, we defined having diabetes as an A1C, which looks at basically the past 3 months of your sugars. We'll just kind of look at that overall as greater than 6.5. But when we talk about treatment, our goal is generally looking at wanting to get it less than 7. That being said, for elderly adults and some certain populations, we do expand that out and look at higher numbers to keep it under, so maybe greater than less than 8.5, 8, that kind of thing. But that would definitely be something to discuss with your healthcare provider on an individual basis. The other thing that we definitely want to get in control of, because it kind of goes hand in hand with diabetes, is blood pressure. And so our goal is to get it to be less than 140/90. And again, something to discuss with your healthcare provider. It may be that you start some medications that will help with diabetes and managing a lot of the complications like Carol and Dr. Zeltzer spoke about, while also managing your blood pressure. And then cholesterol. And so a goal is to lower your LDL cholesterol and your triglycerides. Those are all things that we look at as more not so good or favorable levels. And to increase your HDL, which is actually a good form of cholesterol that we push towards.
Hold on. Let's hold on.
So we have another question here. We'll hold off on this in a second. We'll come back to it.
We'll come back to it.
Smoking cessation is our last point of our track. We want to actively work towards quitting, which Dr. Zeltzer spoke about earlier. It's something definitely to discuss with your healthcare provider when you're ready to do that. Definitely important to develop a plan and then to seek out a good support system to help you with that process. Again, not something that many of us can do alone. So it's great to have support, and it becomes very hard, right? If you're in a home with you smoke and there's other people in the house that smoke, it becomes difficult to quit when you're going to be around that. And so again, trying to seek out and develop a good plan and then a good support system around that. Great resources to use are, especially this top one, 1-800-QUIT-NOW. And they have resources not just in terms of people to talk to, but also options for nicotine therapy, that kind of thing. They can help with that, medications that can help you quit. Other resources are the CDC, smokefree.gov, and there's actually this Quit Start app, which I just learned about, which kind of helps you track this process and offers a lot of good resources. Have it readily on your phone and kind of go through how you're feeling that day, kind of what your triggers are to smoke, that kind of thing. So all very helpful, useful resources for this.
All free too. I'm not sure if that was mentioned.
Yes, they are all free. In terms of community resources to help kind of with all of this and lifestyle management, one big one is the YMCA. And the YMCA has a program for those with pre-diabetes to help prevent diabetes. So help if you are diagnosed with pre-diabetes based on one of those lab tests, and to prevent that progression to diabetes. And it's actually a CDC recognized program that is evidence-based. There's a lot of research that's gone into it, and they implement it through the YMCA's. There's actually grants available for it, so it can be free of charge to a lot of people. It's actually shown to reduce the risk of developing diabetes if you have pre-diabetes by 58%, and even greater percent of 71% in adults that are 65 or older, which is huge. And so definitely something worth contacting the YMCA about and looking into if you've been diagnosed with pre-diabetes and want to prevent that further development. And then depending on where you're at, your local institution or your hospital system or doctor offices or practices may have other programs in place. So here in Wilmington with New Hanover and Vermont Health, we have a diabetes education program. We have diabetes educators that work in conjunction with us to help patients navigate their medications, again, more the dieting, exercise, lifestyle management, the other resources that are available to them. So definitely worth looking into your local institution, no matter where you are, to figure out what programs are available. In terms of diabetes medications, again, not something we'll go into great depth about, but there are many classes of medications that are available. And we use algorithms a lot of times to kind of start which ones will start, depending where someone's at, depending on where their A1C is. If it's very, very high, sometimes we start people on insulin right away. Doesn't mean they'll be on it forever, but to bring that down, if it's lower, sometimes we'll, but not at goal, we'll use other medications, and then depending on the risk factors people have, we might start different medications. And so all of that to say, definitely something to discuss with your healthcare provider about starting medication, and which of those medications might be best for you, because it's not a one size fits all for sure. Dieting again. It's always important again to have a very good support system in place, and so your primary care provider is part of that support system. And so if you're struggling with exercise and dieting and trying to figure those things out, trying to figure out resources around that, definitely worth the conversation with them. I know they'd be happy to talk to you about those things. Last slide here in review. Living with diabetes, as we mentioned, there's well over 20 million Americans with diabetes in the US, nearing 30 million at this point. And so the things that we can all do to be healthy and to feel the best, again, are to eat healthy. I eat a lot of more fruits and vegetables, less sugar and salt, and then again looking at those portions of meals and what we should be eating, getting our physical activity in like we've discussed, taking our diabetes medicine as prescribed, and taking it regularly, and then discussing with our physician, our primary care provider, about whether to start or stop something, what that looks like, what might be best for you. Make and keep appointments with your healthcare team. And so follow-up is super important, which at times it is hard to make all the appointments and get everything done. So we totally understand that, but definitely rescheduling and getting in so that we can have these good conversations with our patients. Checking our blood pressure, our blood sugar regularly, if it's something that you've been asked to do. So not everyone with diabetes does this, but if you've been asked to do that, that's a great thing to do. And again, bringing in that log, and then knowing your ABCs. Again, so that regular A1C test, which we check every 3 to 6 months, keeping up with your blood pressure, and then controlling our cholesterol, and of course, stopping or never starting to smoke.
And then just go back to address that question from Jeffrey really quickly.
Sure.
So the question was, how can HIV meds raise your cholesterol? So there was a slide a little bit earlier, Jeffrey, where basically some of the HIV medication can cause either weight gain or insulin resistance. And it's the weight gain and the insulin resistance that is putting you at a higher risk of developing diabetes. So those can be side effects of some of the ART meds. And if you're kind of going through your own personal risk factors and see that you may be at a high risk for developing diabetes, or you already have diabetes, that would be something to go through with your primary care physician and be like, hey, I saw this webinar. I'm taking one of these meds that can cause weight gain, that can cause insulin resistance. Maybe there's another medication I could be on that is in a different class of drugs that could accomplish the same ART therapy, but doesn't have those side effects.
It's a great question. Just one more thing in the chat. Oh, awesome. Glad that was clarified for you. I guess we can stop sharing our screen for now. Hopefully that was informational and you guys kind of learned something from it. We actually do really appreciate all of you guys interacting and asking questions along the way. It does help us in kind of, being able to provide the proper information for you guys. We'll definitely leave some time open here at the end. I know there might be some other questions that might want to be answered. So go ahead if you have any other further questions.
So I have like 4 questions while you guys was doing the presentation. Hi, everybody. So one was similar to Jeffrey's, but mine is most HIV meds have 1 or 2 of those components, ingredients that was listed. Hence, I'm on Biktarvy. I saw that Bictegravir, that's in Biktarvy, the Dul, whatever, that's in Dovato, and pretty much those are all new ARVs. So what are the suggestions for us, for people who are on those particular ARVs? What can we do? I know you just say, to talk to our, our provider, but then what's our other options?
So full disclosure, I don't know the actual answer because I am not an expert in all of the art therapy medications. But what I will say, just logically thinking it through, typically art therapy is three different medications. And so if you're taking 3 different medications and you're seeing that all 3 of them have those as side effects, can you talk with your healthcare provider about switching out one? And so now you're decreasing your risk by 1/3 or maybe even 2. And so every class of drug is going to have one of those that have the side effect of weight gain or insulin resistance, but try to make it not be one from all 3 classes.
No, so I think you misunderstood. So Biktarvy, right? The ingredients. So bictegravir is an ingredient in a pill, right? Though that's within the Biktarvy medication itself. So that's what I'm saying. So what that particular ingredient is in the medication that I take. So therefore, I would have to take a whole nother drug opposed to just taking that one.
Right. So I understand what you're saying. Biktarvy is a combo medication. And some of these classes increase your risk for having some of these things. Now, it increases your risk. Not everyone experiences these side effects. 1, 2, if you are experiencing these side effects, there are other ways to combat it. We don't want to kind of preach that you should be on a different medication if it's the right medication for you. Yeah. Some of these side effects are, unavoidable in terms of, helping to treat HIV, keeping your viral load low, increasing CD4 counts. That's overall, that's probably the more important thing.
The main goal.
Right. These are just trying to, give you information in terms of if you are starting a new medication, these are some things to look out for and talk to your doctor about.
Be aware
if
of.
you've been on Biktarvy for a while, it's very difficult to change medications with HIV therapy, as because with the virus and if we're changing medications, that can sometimes lead to increased replication and other factors that we don't want to deal with. So trying to combat that is sometimes difficult. And physicians don't always have the answers in terms of, what to do. We want to balance between having, a suppressed, HIV viral load and replication, and also want you to be not gaining weight, not having increased risk for diabetes. But hopefully with this presentation, you were able to kind of see, with dieting and exercise and some of the other options that you have, it might be a little bit, better to help control or maintain some of those side effects.
Absolutely. Thank you. That was a great answer. I have another question. So the next question is, are there any clinical trials to further study people who are living with HIV and who either A, acquire diabetes, or B, are at higher risk for acquiring diabetes?
That's a great question. In terms of clinical trials that are currently out dealing with HIV and diabetes, I don't know of any offhand. With the medical community, it's vastly changing and vastly growing. I think we're in a really good position being young physicians that we can kind of spearhead some of this stuff as well. And trying to, get the word out. And I think it starts here with some of the webinars and getting the information out. People start looking at this and saying, hey, there is a large increased risk for diabetes in people who have HIV, and maybe we should look into this a little bit more. But to answer your question, there are at least none that I know of personally. Not to say that there aren't any, but
so I kind of did the portion where it looked at the relationship between HIV and diabetes, and I will tell you, it was very difficult to find research. There really was not that much on UpToDate, on Dynamed. I looked on PubMed. It was the info that I put in here is almost all the info I could find about the relation between the two. And like I said in the slide, they don't know what's causing it. So they know like some of these Some things are like the art therapy is causing weight gains and insulin resistance. We think that might be why people who have HIV are at an increased risk of diabetes, but there are not specific trials that are looking at that. Why are people with HIV at an increased risk of diabetes? Our working hypothesis is that it's because of the ART medication. But there wasn't further diving into that. So that was, I mean, they need to do that.
Okay, awesome. Thank you. And my last question is, that's for you, Dr. Zeltzer.
Yeah.
Okay. You said something earlier. You said that, people living with HIV are at higher risk for, becoming diabetic. When you said that, were you referring to the people living with HIV who are not adhering to their medication, or the ones who are adhering, or both?
Oh, that's a great question, and I will tell you the research didn't specify. That's exactly what I'm saying. The research is so limited that they did not specify one or the other, and they're assuming in the research they're assuming it's because of the medications. So it'd be people who are adherent to their medications, at least enough to cause this diabetes, insulin resistance, and weight gain. But there is no evidence saying that that is the actual cause, and therefore the research is not specifying just having HIV in and of itself, does that put you at a higher risk of diabetes? We don't know.
Thank you. Thank you so much.
That's a depressing answer to end on. Sorry.
Well, that means that we kind of give you guys some homework to do.
Yeah, that's right.
Yes. Nor does this mean to stop taking your art therapy to try to avoid contracting diabetes.
Yes.
I just want to make sure that is very, very clear amongst all that are listening. But thank you. Those are great questions. Does anyone else have any other questions or anything else that we kind of talked about in the webinar that might need to be clarified? We're definitely happy to try and clear those answers up for you.
I think Jeffrey has his hand up, so I'm going to let him speak.
Awesome.
Yes. Please bear with me because I'm on satellite internet and everything is delayed. I always like to tell everybody that because then we won't be talking over each other. My question is, my mother is diabetic, but HIV negative, and her diabetes has, I'm not for sure of the correct terminology, has risen to where she is now taking shots once a week. And if she gets her AC1 back down, is there possible ways that she can come off of them shots, or is she going to be on them shots for the rest of her life?
So I'll go.
Yes, so great question. It depends on potentially other risk factors that she might have. So depending on which injection medicine she's taking, a few of those that we take one per week are actually medicines that we're finding help prevent heart disease, kidney disease, other things like that. And so if she were to have some of those other comorbid chronic diseases or conditions, it may be that her provider would keep her on that a little bit longer or indefinitely if they found that it was protective for her. Also, if they find that it manages her diabetes really, really well, and that she does well with it and doesn't have any complications, again, it might be a discussion of, do we change it? Do we just keep her on it because she's doing well on it? That being said, some of those injection medicines, whether it be insulin, which generally people take from once a day to multiple times a day, to some of the other ones that are a week or taken once a week, it doesn't mean that you'll always be on those medications or that she'll always be on that medication. Once we control someone's A1C and get their blood sugars really well under control, And we've gotten them to really work on some of the other aspects of the lifestyle management like we talked about, and they're doing really, really well. Sometimes we start backing off of medications to see how they do. And if they consistently stay with good blood sugars and good A1Cs, some people come off of medications entirely, or we just switch them over to a lower dose pill of some other sort, and then they never have to do injections again. So it kind of depends on the person and how well their diabetes becomes managed, and and kind of a discussion between patient and provider for sure.
Okay, I have one more question. Is there any other type of medicine besides metformin that she can take, because she's having so many problems with her digestive system with that metformin?
Yes, so there's a lot of diabetes medications, a lot of them which are you can take orally. So metformin is one of them that we commonly use, but it's also one that, because of those GI side effects, abdominal pain, diarrhea, etc., that patients don't always like taking, and totally understandable. And so it would definitely be worth her having a discussion with her healthcare provider about the other options she has, because again, if she can't, if the metformin is causing her a lot of GI side effects and she's not tolerating it well, we don't want to just continue pushing that and have her have a lot of GI issues. And so definitely a good discussion to have with her provider about the other options, because there are a lot of options for diabetes medications and management.
Great. Any other questions?
I think that's all of the questions. So thank you everyone for attending the Living with HIV and Type 2 Diabetes webinar this evening. Thank you all so much for your time and dedication. We encourage everyone to sign up for SOH Time and follow us on Facebook and Instagram for updates on upcoming webinars. And everyone have a great evening.